Welcome back to the Lung Cancer Foundation of America's World Lung Cancer Day social media takeover. Now, I want you to think about this question. What could take your chances for lung cancer survival at 5 years from 7% to 60%?
That's a pretty big jump, Diane, and I'm thankful that Dr. Osarogiagbon with Baptist Memorial Hospital in Memphis, Tennessee, has the answer for us. Take a listen.
The first question that we have for you as LCFA is working to educate Black Americans who are diagnosed with lung cancer is helping them think or know to ask the question, what is my biomarker? So can you talk to us about what a biomarker is? And after someone finds out about biomarker testing, what are some of the barriers that Black Americans face to getting biomarker testing?
Yeah, thank you. What is a biomarker? A biomarker is a test that you can use to identify the presence of a disease and predict its future behavior. So for lung cancer, we're really excited. There are lots of biomarkers that have come to help us split what used to be a single disease into many different bits of different sizes. That allows us to predict how the cancer is going to behave and what treatment is most likely to benefit the patient in terms of surviving the cancer and the quality of life in response to cancer treatment. For African Americans, like anybody else who are diagnosed with lung cancer, understanding what the best treatment is likely to be, how the cancer is likely to behave, how likely we are to be able to overcome the cancer, obviously is at the heart of the matter. No different for African Americans than it is for anybody else. So African Americans, like anybody else who are unfortunately diagnosed with a lung cancer, should be asking the question, what type of lung cancer do I have, including what type of biomarker subset of lung cancer do I have in order to know what is the best treatment for my lung cancer. We know, unfortunately, that all of this is still relatively new. Doctors and healthcare systems are still learning about the importance of biomarkers. And therefore, like anything new, it takes a while for everybody to be aware, for everybody to gain access. And the usual people who get left behind, the poor, the relatively underinsured, the less well-educated, and yes, indeed, African Americans oftentimes get left behind with these innovations, such as biomarker testing. The barriers really, in my mind, are provider and institution and policy-based. I do not think it is fair to talk about person-level barriers. A patient diagnosed with lung cancer, Black or white, does not really want to get inferior care. If inferior care is provided, I think we have to turn squarely on the clinicians and the healthcare systems and maybe our social policies that drive who pays for what, to ask the question, why are you not providing uniform access to people? So at the provider level, there is a real challenge. Doctors just don't know as much as you would imagine that they should. Again, this is relatively new information. It is moving very fast. So not everybody can keep up with this rapidly evolving knowledge base. In particular, cancer doctors who do a little bit of cancer here and there may not be fully aware of this fast-moving space that is lung cancer. So if you're seeing a general oncologist, chances are you need to be really pushy about asking to make sure you get the right testing to get the right treatment. Chances are if you're seeing a thoracic oncologist, a cancer doctor that specializes in lung cancer, you are way more likely to get the right test done, leading to the right treatment. So that's an example of provider level barriers. Institution level barriers also exist because these tests, they may be done in-house within the hospital's pathology lab, but in most cases, most institutions don't have the ability to do these tests. They have to be done by an external third-party vendor. If between the provider and the healthcare system, there has not been an effort made to organize how you get the right patients tested, then it is much more likely that patients will fall through the cracks and never get their biomarker tested. So again, speaking about African Americans, where do African American lung cancer patients tend to go for their care? It tends not to be the comprehensive cancer centers, the NCI designated cancer centers, where you're more likely to find thoracic specialists, cancer doctors who specialize in lung cancer. They tend to go to smaller practices, community-based practices, practices that, quite frankly, tend to provide care for relatively underinsured people. So they tend to lack the infrastructure to get testing done. That is actually a much bigger barrier that needs to be fully acknowledged. And then at the policy level, society level, biomarker testing is relatively new, and new things tend to be somewhat more expensive. So people who are underinsured may find it harder because still, even in today's world, some insurance companies may be more resistant to providing coverage for the types of biomarker tests that we are increasingly demanding for our patients. And unfortunately, we know that African Americans are less likely to be fully insured than others because of the socioeconomic and longstanding, racism that has existed in this country that has led people to be socioeconomically challenged.
I think those are all great points. And Brandy Bryant, who we talked to earlier in the podcast, talked about how she was put on chemo immediately. Can you talk a little bit about how important it is to truly understand what type of cancer you have by asking, what is my biomarker? And then also the importance of clinical trials so that you are getting the most cutting edge treatment that you can possibly get.
Yes, a big deal. So the issue of what treatment to give is vital. We are really excited that we're moving rapidly in the lung cancer world from the dark ages where all we had was, chemotherapy that had whatever benefit it had, but came with a lot of side effects. And that benefit was really limited. To a world in which you can actually find different types of lung cancer that you can use a specific treatment for. I'll give you an example about the benefit we're talking about. If we're talking about patients with stage 4 lung cancer, if you took all of them together and you just look at those who get chemotherapy, not distinguishing the subset of lung cancer, just give everybody chemotherapy and that's it. The aggregate 5-year survival of people treated that way, stage 4 lung cancer, the most advanced stage, is about 4, maybe if you want to be generous, up to 6%. That's 4 to 6% of such patients who don't have any characterization of their lung cancer, just lung cancer, stage 4, and we give you chemotherapy. 4 to 6% can expect to survive 5 years. Now, if you look at the subsets of lung cancer that we're talking about, so for example, the subset of lung cancer that has the ALK mutation, which is present in, we think, anywhere from 2 to 7% of all patients with lung cancer. Those patients, given one of the oral targeted agents for that specific type of lung cancer, the 5-year survival rate, as far as we can tell from old clinical trials, is in excess of 60%. Wow. So you go from 4 to 6% 5-year survival to up to 60% if you get the right treatment for the right cancer. as with ALK mutated lung cancer, so with some of the other subsets, the EGFR mutated lung cancers, the ROS1 mutated lung cancers, the BRAF mutated lung cancers, the RET, the MET exon 14 mutated lung cancer. There are at least 9 subsets of biomarker-driven lung cancers, and that continues to change all the time. So that's why it's vital that we get tested so we know which treatment would benefit us. Now, it is true, though, that the biomarker test results sometimes can take a few weeks to get back. And there's the natural fear that, okay, wait a minute, you just told me I got stage 4 lung cancer. I know lung cancer kills. Now we hurried up to find out I had lung cancer. You're going to tell me to wait? How is that even sensible? And the answer is, it depends. Now, if you have a lot of symptoms, so basically the lung cancer has clearly grabbed hold of you and it's dragging you down a hole, yes, indeed, we may not have 2-3 weeks to wait on a biomarker test result. And our hand is forced. We have to rescue. And chemotherapy, we know, can buy us some time. But that is the minority of patients. In most cases, patients do have the luxury of a few weeks here and there to wait. And the point we need to emphasize is that that wait, as uncomfortable as it might be, is very well worth doing. And I will tell you, as a lung cancer physician, that most of my patients are willing to wait. When they know that the difference we're talking about is the possibility of taking a pill once or twice a day with this tremendous possibility of benefit versus coming in every 3 weeks to my chemotherapy shop to get IV fluids with all the side effects, IV infusions with all the side effects and all of that. Most people are very happy to wait. And it is the doctor's job. It is the doctor's job to explain to the patient why that wait, as counterintuitive as it might seem at first, is well worth it. And again, we have to turn squarely to the doctors because the patients don't know. If the doctor hasn't told them, hasn't taken the time to explain to them, people feel like, well, you just gave me this bad news. This is, I got to do something about it. I want to engage in the arena, so let's get going already. But in most cases, it is safe and better to wait. Now, there's another reason, a really important reason why it is important to wait. Now, these days, we use chemotherapy with immunotherapy to treat patients with lung cancer who don't have any targeted therapy options. And that is quite effective, okay? The problem is, if you're going to use immunotherapy for some of these types of lung cancers, such as the EGFR mutation or ALK mutation, well, it's not going to work, okay? So you're going to be giving treatment that has side effects, very expensive, that we would have been able to predict won't be effective. That's one. And then, well, if you give it immunotherapy with chemotherapy, yes, that can work. The problem is when you now later on find out that the patient has a biomarker identified subset of lung cancer for which there's now a very effective targeted therapy, a pill in most cases that you can take by mouth. Well, you run into the problem that that pill is now, because of what you have been treated with before, now more likely to damage your lungs. Wow. You're more likely to get pneumonitis from the pill that will still be effective, but the side effect and the danger to you becomes worse. So that little error of going with the wrong first stab can have devastating consequences. Again, that's why we need to hold our doctors and our healthcare systems accountable to ask them, why are you not asking me about biomarker testing for my lung cancer?
Jordan, I won't quickly forget this interview. When Dr. Osarogiagbon said that knowing your biomarker increases your chances for surviving lung cancer from 7% to 60%, I remember physically gasping. I was in shock.
I mean, it's a massive number, and it's a number that people who are watching today absolutely need to remember and share. I mean, you just think of all the lung cancer patients that we've met over the years who didn't know their biomarker before they started treatment. This is a really important conversation every lung cancer patient needs to hear and needs to have. I wonder how many of you knew to ask about testing, or if you did your biomarker testing and if it made a difference in your treatment and quality of life. Be sure to let us know in the comments. And thank you so much for watching.